Good evening, everybody who are watching this program from India, and good afternoon to those who are watching it from the United Kingdom. Welcome all of you to the live program number 143 at Orthopedic Principles. Today, our guest of honor is distinguished faculty, Dr. Abdula Hanoun from Manchester, United Kingdom. Dr. Hanoun has earlier lectured with us, and that was a fantastic lecture on biomechanics of the knee. He has completed his fellowship with the European Board as well as the Royal College of Surgeons. And Dr. Hanoun is instrumental in training the FRCS candidates in the United Kingdom. And his lectures are very, very popular in the UK. So today, it's my great honor to introduce you to Dr. Abdula Hanoun for this fantastic live program. Over to you, Abdul.
Thank you, Dr. Gopalan. I'm really privileged to be invited for this successful program, Orthopedic Principles. And I'm really happy and be humbled by the principles that this program is teaching people for free in India. Without further ado, my talk today is about fractured neck of femur for the FRCS. I will be focusing on how you pass the FRCS if you get any question about the fractured neck of femur. This is a very, very important topic. It comes very frequently in the exam, and it is faced daily in your practice. Because some people will be preparing for the international exam and others will be for the UK exam, I'll try and use as broad guidelines and principles as possible. I have to mention that this talk has been the material has been prepared by myself and by Shwan Hinari, who is another fantastic trainer in the FRCS mentor group. And in fact, he was my trainer before, and we became very good friends. So credit when credit is due. So what will this talk cover? As I mentioned, I will touch on the guidelines that I have used to prepare this. I will talk about the epidemiology and risk factors for fractured neck of femur. I will mention how they are presented and what is the best way to diagnosis according to the guidelines. I will touch on the classifications. I will mention the management, and I will divide the management into medical management and surgical management. The talk will focus on fractured neck of femur in the elderly. However, I will be touching about the fractured neck of femur in other circumstances like pathological fractures, in the young, stress fractures, and whenever there is an ipsilateral fractured neck of femur with a shaft of femur. I hope you will find the topics covered very relevant and very important, and I hope that we would all learn from this. So, the main guidelines, if you are going to go for the FRCS UK version, is the NICE guidelines. I would recommend for all of you to download the guidelines and try and summarize them yourself. It is a very, very important and relevant topic, and the guidelines keep changing. Every 2 or 3 years, a new version or addition or addendum is added. As you can see here, it was published in 2011, and since then it had 2 addendums. The last one is in May 2017, and you would think that a new addendum might come soon. In addition, there is the World Health Organization book on the fractured neck of femur, which is slightly dated from 1994, but there is a BOST guidelines, which you can see on the left hand screen, and with it you would find some other materials which you can use as resources for your study. That is mainly for the FRCS exam. For the international candidates, there is the AAOS, which has come up with a comprehensive summary on and guidelines on the management of the fractured neck of femur for the elderly. Why is it so important? The thing is, it is very common worldwide, and the more advanced your nation is, the more you will see it. The population is growing older. For example, if you look here at the Americas, this is World Health Organization statistics. At around the year 2000, there was 311,000 fractured neck of femurs in the Americas. Compare that to about 350 in 2017. That's about more than 10% increase over 20 years. And this trend is only going to increase. Traditionally, whenever we talk about the fracture neck of femur, we have to mention the blood supply to the neck. And as you know, it comes from the deep femoral artery, dividing into the medial, which goes posterior, and the lateral, which goes anterior femoral circumference artery, in addition to the supplemental blood supply through the ligamentum teres and the intramedullary. And the reason for that is it has, as we all know, bearing on the management. Now, the risk factors for fragility fractured neck of femur is mainly two: osteoporosis and osteomalacia, which makes the bone more prone to fracture, and frequent falls, which leads to the fracture. And all the rest of the risk factors lead to one or both of these risk factors. It has been noted that whites have higher risk for developing fractured neck of femur, and that can partially be explained by higher life expectancy. However, this does not explain fully the trend. The other risk factors are medications, which makes the patient more prone to to falls, or weaken the bone, like steroids. The more aged you are, the higher risk of developing a fracture. Females have a temporarily increased risk factor around the postmenopausal time, but this tends to catch up with the men's risk at an older age. There are environmental factors which include living in poor conditions, and by poor I don't mean poverty, I mean unkempt, like lighting, footpaths, and slippery surfaces. A previous fragility fracture, either in the patient or in the family, is a risk factor for developing one, in addition to poor nutrition. Classifications. In the exam, you're not expected to mention the classification, so they will not ask you about a classification. However, it is traditional to divide the fractured neck of femur into two broad spectrums. So there is the intracapsular and the extracapsular, and the reason is to do with the blood supply to the neck of femur. The intracapsular is divided into undisplaced and displaced, and the extracapsular, again, traditionally is divided into basicervical, intertrochanteric, subtrochanteric, and in the intertrochanteric, we have a special type called reverse oblique. This diagram is taken from NICE guidelines. Notable classifications. There are three notable classifications which I believe you should know about because they have a bearing or a historic importance. So the first one is Gardner's classification, which is very commonly used across the world, which divides it into two groups, types 1 and 2, which are undisplaced, and type 3 and 4, which are displaced. Note that this only applies to intercapsular fracture neck of femur and only applies to AP views. That's why nowadays it's been superseded, although it's traditional to talk about it in trauma meetings. The other notable classification is the Powell's classification, and again, it applies to the intracapsular, and the reason they mention it is because of the angle of the fracture has a bearing on the forces going through the fracture and the potential for non-union depending on the treatment. The third classification is the AO classification, which is a comprehensive classification of all fractured neck of femurs, and it is widely used in research. Although you are not expected to mention the details of this classification or any other classification, but it is worth knowing, especially if you are involved in research. Presentation. Patients having a fractured neck of femur present typically with a trivial fall or injury resulting in pain in the hip and reduced ability to weight bear. There are slightly different presentations depending on the type of fracture. So displaced fractures usually lead to shortening and external rotation of the limb, in addition to inability to straight leg raise. Impacted fractures, however, may not show the described above deformity. And they may have moderate pain, and sometimes patients are able to weight bear for a period of time. passive range of movement can cause some pain. Trochanteric fracture can lead to moderate deformity, but the patients will be unable to straight leg raise. The subtrochanteric fracture, however, is probably the one that causes more deformity and can bleed significantly. Some patients present with a prior symptoms, prodromal symptoms before developing the fracture, and it is very important to establish that when you are taking the history. The diagnosis. After taking full history and examination, and this is important to state in the exam and not to forget, the main way of diagnosing a fracture is a plain X-ray, AP, and lateral cross table. This is the important thing that must be done in every patient. It is not always positive. So sometimes patients would have fracture with negative X-rays. And what do we do then? The NICE guidelines state that MRI is the investigation of choice. Alternatives are CT scan, and this can be done routinely in subtrochanteric fractures if you want to establish the pattern of fracture and the quality of the bone. Radioisotope is another alternative. Commonly, people do a repeat X-ray 24 to 48 hours in some countries where the MRI and CT scan are difficult to obtain. Studies shown that this has poor sensitivity and it is not recommended. When you are suspecting a pathological fracture, it is mandatory to have a full bone X-ray. Management. In the exam, it is very good to divide the management into medical management and surgical management. And the medical management can be divided into preoperatively and postoperatively. This is how you should phrase your answer in the exam. For the medical management preoperatively, first establish a very good history and thorough examination. And what you are trying to aim for is to establish the mechanism of injury, the pre-injury symptoms, because this can reveal either an osteoarthritis developing in the joint beforehand, or atypical fractures, which we will be talking about, or pathological fractures. You have to establish the neurovascular status and document that, again, to compare it for post-operative state. You have to document the pain score and core body temperature, fluid balance, nutritional status, history of continence, mental state, and previous mobility and function, in addition to previous social circumstances and drug and medical history. This would have a bearing on the timing of surgery, especially if the patient takes anticoagulation or needs supplemental treatment if the patient is on steroids. All of this is part of the NICE guidelines, and when you are in the exam, you can say, according to the NICE guidelines, I will record, and you mention all these. Rest of the medical management, you have to offer the patient pain relief. And this could be in the form of oral, IV, IM, or nerve block. You have to prevent the patient developing pressure sores, and this could be by good nursing care, making sure that the surfaces are dry, documenting of the skin condition, and using special mattresses. You have to prevent hypothermia, and there is a specialized guidelines on how to deal or to stop the hypothermia from developing in patients. Note that some patients would have had the fall several hours before presenting to accidental emergency because of the inability to call for help as they live alone. And this is more common in the Western countries. You have to do blood tests, and the basic blood tests are full blood count, electrolytes, group and save. You do clotting screen if the patient has anticoagulation. You do a chest X-ray if there is a need to, and this follows your local guidelines. ECG is a mandatory. If you note any imbalance in the electrolyte or fluid, you have to correct that as soon as, in order to have a prompt surgery as soon as possible. And you have to correct anticoagulation. And again, you follow the guidelines, or you speak to the hematology team to help you with that. The next management is post-op, and I started with this before taking the surgery to give full time for the surgical management. it's very, very important, and this is an often missed or ignored part, but this has a big bearing on the patient's outcome. And if you are in the exam and you start talking about this, it will make you look really good in front of the examiner as a holistic person. This starts with multidisciplinary approach, and that involves the orthogeriatricians, anesthetists, physiotherapists, occupational therapists, and nursing team. And the NICE guidelines state that orthogeriatricians should be involved and start seeing the patients within 72 hours of admission. And the reason for the 72 hours is to cover for the weekend when some hospitals would struggle to have orthogeriatricians over that time. You have to consider falls prevention and bone health immediately as you are presented with a patient who has a fractured neck of femur. And the reason for that is you want to stop them having another falls and further fractures. You have to start the physiotherapy early, in the same day of the operation if you can, but most important, well, at least the second day. You have to review the patient daily by the multidisciplinary team. And for that, you review their progress daily, return to their normal function, and their physiotherapy progress. In addition, you actively look for signs and symptoms of any complication. And you start planning for discharge from day one. And by that, it means you look at the home circumstances, you see what you can adjust to allow the patient to go home as early as possible, or to a step-down place where they can rehabilitate before going home. Of particular importance is osteoporosis, as it is the main cause for these patients having a fracture. And usually there is a separate department looking at that, but you need to be aware of this. Again, this is done as a multidisciplinary approach, looking at fragility fractures, assessing the bone health, and looking how we can reduce the risk of that. This takes a form of formal assessment using online tools like a FRCS. You do a routine DEXA scan once the patients recover fully. There are special clinics to stop patients falling, and you start treatment of osteoporosis while the patient is an inpatient. And this can be in the form of vitamin D and calcium. You follow the national guidelines. Now let's talk about the surgical management. And the surgical management, I've divided that into timing of surgery, treatment of intracapsular, treatment of extracapsular, treatment of subtrochanteric fracture, and then a brief talk about the complications of surgery. Concerning the timing of surgery, it is important to do the surgery as soon as the patient is fit. There are several studies and accumulating evidence that any delay in surgery will result in prolonged hospitalization, worse outcome, and even morbidity. Hence, all the guidelines, national guidelines, the NICE, the SIGN in Scotland, the AAOS, encourage doing the surgery within 48 or even 72 hours, of the time of admission or diagnosis. Now, surgical management. The intracapsular neck of fracture in the elderly. And I'm only talking about the elderly here now. The conservative treatments can be used in the frailest of patients with very limited life expectancy, or if the patient presents late and they have been weight-bearing on that area with minimal trouble. In these cases, you follow the patient frequently with routine x-rays, and if there is any chance or change in the preferred outcome, then you move to surgical management. So the surgical management in the undisplaced is the main form of management. What you need to check is it really undisplaced? And then you have to consider doing either a DHS or a cannulated screw. And there are two big groups of people. So some would follow the cannulated screw and they believe that it has better mechanical properties, and some would do the DHS because it's more stable. There is no proof that one is better than the other. You do what you feel is better and what is best in your hand. What is more important is the positioning of the cannulated screw has to follow the area of strong bone to make it more stable, and it is now more accepted that you have to use a reversed triangle formation. If you are using a DHS, then 2-hole DHS is good enough, and some people would add a derotational screw to stop it, especially if you're doing a left-hand side, and while you're turning the DHS screw, it may cause some displacement. NICE guidelines doesn't prefer either of the two. I mean, doesn't prefer one over the other. Now, for the displaced fracture, however, there is no role for conservative treatment. But is it really, the reason is there is 40% high reoperation rate with AVN and non-union if you treat them conservatively. The methods are either to do a hemiarthroplasty or total hip replacement. Fixation doesn't work. There are two schools again, hemiarthroplasty or total hip replacement. Previously, everyone used to get a hemiarthroplasty. There is growing evidence that total hip replacement provides better function, better physiology in the long term, and better return to normal mobility than hemiarthroplasty. The price is, it is slightly more expensive, and there is an increased risk of dislocation. There are guidelines on when to apply this, or hemiarthroplasty or total hip replacement, and these are based on the patient's physiology. So if there is a high risk of dislocation, like in Parkinson's disease or advanced dementia or even prior stroke, then hemiarthroplasty is recommended. If the patient has poor mobility indicating poor physiology, again hemiarthroplasty. The national guidelines in both America and the UK recommend total hip replacement for the rest. Questions remain about whether to use cemented or uncemented, bipolar or monopolar, dual mobility, or conventional total hip replacement. And unfortunately, there is no strong evidence to suggest any of these is better than the other. So you can say that there is no evidence, and there are some studies ongoing to answer these questions. For example, there is a recent study started to look at the cemented versus uncemented. Moving on to the extracapsular fracture neck of femur. The common methods of management is DHS versus IM nailing. The fixed angle plates are out of favor now. The majority are treated with DHS. There is a traditional trend not to treat reverse oblique with a DHS, stating that there is a high risk of screw cutout and implant failure. Recent studies have found that this is not entirely true, and that if you manage to reduce the fracture anatomically, then a DHS is good enough. Again, when there is a loss of lateral wall, comminuted intertrochanteric, or fracture extended into the subtrochanteric area, traditionally the IM nail have been used. Apart from the extension into the subtrochanteric area, I think recent studies have confirmed that DHS is good enough. Nails are more expensive and probably bleed a bit more. However, in these areas, it is not wrong to say that you will treat it with IM nailing as long as you mention that you are aware of the evidence. Moving to the subtrochanteric fractured neck of femur, and these have almost universally been treated with IM nailing. The only controversy is whether to use a short or a long nail, and the majority would feel that the long nail is better, especially in the more distal fractures. The controversy is whether you are going to use a piriformis or trochanteric entry, and this again is almost non-relevant nowadays because of the new designs of the IM nailing allows both. The more important is to have an anatomical reduction before you insert the before you start reaming. Otherwise, you will have an off-centric ream, and this will position the IM nail in non-optimal position, leading to deformity, inflection, abduction, and external rotation. There are methods to help you to position the IM nail in ideal position, which you can use wires or positioning screws or even open reduction with clamps to try and achieve that. You mentioned in the exam that you achieve reduction before you do the reaming. This is very important. Moving to the complications of surgery, we all know these, and you should know them by numbers. I will not waste time on that, apart from mentioning that there is avascular necrosis, non-union, generalized bleeding, generalized complications like bleeding, nerve injury, medical conditions. The more important thing is how to phrase your answer, and I would phrase it as either early or late, or I would say specific and general. You need to be aware the relative risks of dislocation between the hemi and total hip replacement, DHS and IM nailing, and fixation and non-fixation. Moving on to what happens to the fracture, intracapsular fracture neck of femur in young adults. These are unique because, number one, young adults mean that their bone is stronger, and that means they had a significant force to lead to the fracture. This means that they had other injuries at the same time, more likely. In addition, the soft tissue would have had significant more injury. So who is young? It is difficult. Some people consider the young, anyone younger than 65 is young. Others would debate that it is a physiological definition. My take on it is a young person is a person who needs significant injury to cause the trauma. Anyone who had a trauma resulting from a trivial injury is physiologically old, and then you treat it as old. So the questions we ask about the treatment in young for intracapsular neck of femur is, number one, the timing of surgery, quality of reduction, how you achieve the reduction, and whether you need to do capsulotomy or not. Traditionally, the surgery was considered urgent to try and preserve the blood supply to the neck and prevent avascular necrosis. And this is recommended in the AAOS recommendations in America. So you can state that. Having said that, recent evidence suggests that it is not as important as previously thought, and that you have a little bit of a leeway to optimize the patient before doing the surgery. I would not use that as an excuse to delay the operation, but I would say that properly prepare the patient for surgery is far more important than taking him to theater early. Quality of reduction has been consistently found to be the most important factor in the outcomes in these patients. So it is far more important to spend time reducing the fracture fully than to rush into doing an operation by someone who is less experienced. Whether to do a closed or an open reduction is depending on the fracture circumstances. People try to do closed reduction using the Leadbetter maneuver, and you would be expected to explain the Leadbetter maneuver in the exam. But it is sometimes easier to open the fracture and reduce it, and some people use the anterior approach for that. Do you need to do capsulotomy if you manage to do a closed reduction? Studies showed that it has no proven benefit, and you can look at this paper, although it is from 1997, but no more. There are other people, papers have described that they have some effect, but it is not proven 100%. The fixation method is again either by using cannulated screws or DHS, depending on what you prefer. We move to pathological fractured neck of femur. And these are unique fractures. However, they present like a normal fracture. You have to have a low threshold for any elderly patient presenting with a prior pain before the injury, and the injury happening with minor or even no trauma. So you look actively for this. And as we mentioned earlier, you do a full-length femur for these. You look carefully for signs in the X-ray. And the management here differ because you can wait. So it can go beyond 72 hours before fixation while you do investigate the reasons for this. So what you look for is this primary or secondary? And if it is secondary metastasis, then where the primary is. So this would follow a multidisciplinary approach with the oncology team and sometimes with other specialties depending on the cause. You take full history looking for red flag signs. You ask about previous history of cancer or active cancer elsewhere. You examine the patient fully for the presence of signs of other cancers, and the common places would be the thyroid or breast. Other areas could be the renal or lung, sometimes multiple myeloma. In the investigations, we mentioned you do a full leg X-ray, APN lateral, you do MRI of the whole femur, you do CT chest up to and pelvis, and you do bloods, including myeloma screen and other cancer markers, depending on the history, including, for example, PSA or CA146 or whatever. You do bone profile as well. The surgical management, in that you have to consider that these patients may not heal. So you do the planning accordingly. So you have an implant that is robust enough to outlive the patient. Sometimes you may have to do a preventative operation and you rely on Merrill's score to determine this. And again, you would be expected to describe the Merrill's score. Again, so this is outlining the pathological fracture. There is a different type of pathological fracture. We call it atypical fracture, which happens on the stress side of the bone as a result commonly of prolonged use of bisphosphonate. However, there are other causes of it, like non-Hodgkin's lymphoma, hypophosphatemia, osteoporosis, vitamin D deficiency, and rheumatoid arthritis. Patients usually present with prodromal symptoms. I hope you can see, but on the other side here, you can see thickening of the lateral cortex, indicating a possible potential fracture in the future. Again, you investigate this with full-length femur X-ray, and you do X-ray of the contralateral side because there is a high percentage of it appearing on the other side. You do MRI scan to show impeding fracture when the patient presents with unexplained pain in the femur, and this can sometimes show it before the X-ray does. The management is you deal with it if it is broken like any other fracture neck of femur, but you can do a prophylactic nailing on the other side as planned semi-urgent procedure when you find out if they had one fracture. The medical management is in the form of a holiday from the bisphosphonate to allow to reduce the risk of this happening again. The mechanism of fracture is a propagation of microfracture because of the impairment of osteoclasts' activity secondary to the bisphosphonate. So what happens normally is whenever you have minor injuries, microfractures occur, and osteoclasts start by clearing that area to allow the cutting cone to go there and remodule the area. But if the osteoclasts are dysfunctional, then the whole process doesn't happen, and instead the microfracture propagates, leading to a full fracture. And that's why it happens at the stress side of the bone. And again, you would be expected to explain the mechanism of this. Diagnosis happens by having a major and minor condition. So major conditions, you have to have 4 of these. Minor conditions are there just to help you, but they may not be, they are not part of the compulsory factors to make the diagnosis. I will leave you to read that on your own, and they are available on the AIO website. We'll talk about the ipsilateral shaft and neck of femur fracture, which can happen commonly in high energy trauma. So whenever you get a fractured shaft of femur, you have to actively look for a fractured neck of femur in these, as it can happen in 1 to 9%. And I think it is more towards the 9%, as the older studies were relying on X-rays, which have 12% negative, more than 12% negative. And in fact, even CT scan has 12% false negative in finding these. So some people advocate using MRI scan whenever you get a shaft of femur fracture. This is impractical in many settings. And I would encourage to use a thin cut CT routinely, but be aware that this can still be false negative, and intraoperatively, when you are dealing with a fractured shaft neck of femur, have a low threshold to doing a neck X-ray repeatedly during the operation to exclude that. And this is a important couple of studies to look at whether to use CT or, the debate is about whether to treat both with one implant or two implants. And the studies are showing two different opinions. So traditionally, people used to treat them with two separate implants, citing that if you use one implant, it will result in higher complication rate. A new evidence suggests that if you reduce both anatomically, then the outcome is as good. Having said that, it is more challenging to have anatomical reduction for both of them at the same time if you are using one implant. So I would still advocate using two separate implants, and I would state that the reason for this is I would then be able to reduce both fractures anatomically better. And again, a second debate is whether to start with the fractured neck of femur or with the shaft. And each method has its proponents. However, the overwhelming evidence is to give priority to the fractured neck of femur, as the worst outcome of fractured neck of femur are worse to the patient than worst outcomes of the shaft of femur. Last bit is the stress fracture neck of femur. This is a unique type of fracture neck of femur affecting mainly athletes and young patients, especially young military early recruits. It has two stages, initiation and propagation, and this happens because of repeated submaximal stresses at the same site, which is the neck of femur. If you are presented with a young female patient with a stress fracture, you have to make sure that you excluded the female athlete triad, which has anorexia, amenorrhea, and osteoporosis. And you send them for medical treatment for that. When the fracture occurs, it can occur either at the tension side or compression side. The tension side is the superior part, as the fracture the bone goes down with your weight bearing, leaving the tension side on the top and compressing the inferior side. The tension side has worse prognosis than the compression side. The presentation is gradual pain in the neck of femur, in the groin and the hip after a period of prolonged increased activity. This usually responds well to rest and reduction in the activities leading to the fracture. The diagnosis is usually with a plain X-ray AP and lateral. Again, it can miss it sometimes, so MRI scan is routinely used in these cases. In the MRI scan, if you see an effusion in the joint, it has poorer prognosis, and people advocate prophylactically treating that surgically and not to wait for the fracture to propagate before you do so. Of note that you can follow this with MRI scan if you decide to treat it conservatively, making sure that the fracture heals fully before you advise patients to go back gradually to their previous level of activity. One risk factors is a sudden increase in the range of in the activity level. Hence, people have advocated giving a tolerance building exercises to recruits, and that had resulted in dramatic reduction in the incidence of this injury. That is all that I had to tell you today. I hope this was useful. I hope you benefited from it, and I will leave time for you to ask questions.
Thank you, Abdullah. Very comprehensive presentation. You have covered almost the entire spectrum of questions that could appear for the FRCS with respect to the topic. A few questions. One is, suppose a patient comes with a fractured neck of femur who is on clopidogrel. So how do you really need to wait, or can we go ahead with surgery? What does the guideline say, the NICE? And okay. Academy has said that the evidence is quite limited. The American, absolutely. What is the NICE and what is it being followed there?
Okay, I can't remember on the top of my head what the NICE guidelines state exactly with these, but your exam answer would be, I would discuss this with the hematology and cardiology teams, because usually patients on clopidogrel for a medical reason, and you have to address that reason and make sure that the patient is safe to proceed. And they may need to have alternative method of coagulation, anticoagulation while you've stopped the clopidogrel. My understanding is a fractured neck of femur is an emergency. I don't think you need to stop it, to delay the surgery for that. You discuss it with the hematology, and my understanding is you may have to give them fresh platelets to compensate for that and proceed with the operation. However, the exam answer would be, I will discuss with the hematology and cardiology and consult my local guidelines.
The other question is regarding the blood transfusion. So suppose a patient has a low hemoglobin. What is your threshold that you need to transfuse them pre-op or post-op?
Again, you follow your local guidelines. It sounds, like a cowardice answer, but this is what they expect you to say, because the guidelines have been developed for a very good reason. You have to weigh the evidence against and for before you make that a decision. And if someone has done that for you, it's very easy for you and safer for the patient to follow them. So going back to your question, I would say I would follow the local guidelines, and commonly in the UK, the threshold has been set as 80 milligram per deciliter, but you waiver that if there are some circumstances that would force you either way. For example, patients who've been on this level for very, very long time would have more tolerance for that than someone who normally would be 120 and suddenly they present with 80 milligram, for example, in subtrochanteric fractured neck of femur. Then I would have a lower threshold to start transfusion. Again, you say, I will consult with the local guidelines and I will speak to the hematology colleague who would give me a proper advice, taking into consideration the general patient's condition and the anticipated blood loss during the operation.
Another question in similar lines, is there a role for tranexamic acid?
Absolutely. Having said that, it is not commonly used in fractured neck of femur. The reason is the amount of blood loss in typical fractured neck of femur is 200 to 400 milliliter, which is a small amount, well tolerated by the patients. Having said that, some people would routinely advocate giving tranexamic acid before any operation, or if they anticipate bleeding to be significant, or if the patient is already on anticoagulation, for example, if they are taking, as you mentioned earlier, clopidogrel or aspirin.
Okay, thank you for that. Senthil is also in our Zoom room. Senthil is a staff orthopedic surgeon in Texas. And Senthil, your questions to Abdullah.
Abdullah, it's a wonderful presentation. So
thank you.
I know this is more kind of towards the trainee and FRCS exam. So what would be the trainees' answer if the examiner asks them, what's your preference when it comes to cemented versus uncemented hemiarthroplasty for intracapsular femoral neck? I know the guidelines doesn't give anything. So what's your preference? What would you recommend the trainees to frame their answer?
Okay, since we don't have evidence, so it is up to you to answer it as long as you have a logical scientific reason for stating that. So my answer would be, and this can be differ, so if you please chip in if you have a different answer. My answer would be, I would use cemented hemiarthroplasty. The reason is, although there is no definite scientific evidence to suggest that, but we know from the NICE guideline, total hip replacement in the elderly, it is better to use a cemented. So extrapolating that evidence, I would use cemented for elderly patients coming with a fractured neck of femur, because the same evidence that supports a cemented total hip replacement could be used for these. And this would be my answer. But you have to be honest and say, we don't have a definite answer specifically for this group of patients.
Sounds good. I don't have any other questions, Hitesh. Anything for you, from you?
Before we conclude the session, one last question. What is the DVT prophylaxis management that is recommended?
Okay, so again, there are some specific guidelines in the NICE website for prophylaxis of DVT. They talk about preoperative, intraoperative, and postoperative, and they talk about mechanical and medications. So apart from general methods of hydration, general assessment, and streamlining, stratifying the risk factors for developing a DVT, the mechanical side is to use a foot calf pump or TED stockings, and medical, and that can be in the form of low molecular weight heparin, tinzaparin, or other methods like dabigatran, replaced by aspirin at around 14 days after the operation. And this usually for about 35 days. However, for specific periods of times and specific exact first line, second line, please refer to the NICE guidelines.
And the dose
And
of
obviously,
aspirin, and the dose of aspirin, is it 325 milligram?
150.
Okay, because in the recommendation, I mean, aspirin to be as effective as an anticoagulant, the dosage is sometimes debated, because in a couple of the studies they have said that 325 mg single dose per day. But the problem is elderly patients' risk of gastric ulceration is going to be higher, isn't it?
Absolutely. Whatever you give, you have to accept that it has its side effects. So, for example, the more potent the anticoagulation, the more risk of developing bleedings elsewhere, intraoperatively and postoperatively, including gastric and brain hemorrhage. And the less potent, the more risk of DVT and PE. So it remains a debate, and it's very difficult for me and you to make that decision. And that's why we have to rely on these NICE guidelines, or AAOS, or whatever national guidelines there is.
Okay, Abdullah, I think that's all the questions we have. We had a fantastic session with you, and that was lovely to listen to all the concepts that you've been following and training these young residents towards the fellowship exam. It was very nice of you to come over and give this lecture, and we really look forward for another one later on whenever you have time.
Thank you very much. I'm really privileged to be helping with you this charitable work of yours. Thank you very much.
Thank you, Abdullah, and thank you, Center.
Thank you, Abdullah. Great work. Thank you.
Good night and good evening.